Good evening, and thank you for joining us for tonight's webinar, Cancer Clinical Trials and Precision Oncology, What GPs Need to Know, in partnership with St Vincent's Health Network Sydney. My name is Ruby Van Cool, Cancer Prevention and Control Program Officer at CESPN. Also with us from CESPN is Lauren Thomas, CPD Program Officer. I would like to start tonight by acknowledging the traditional custodians and sovereign people of the land across which we work. I recognise their continuing connection to land, water and community, and pay respect to elders past, present and emergent. I also extend that respect to any Aboriginal colleagues who may be joining us tonight. Please note that this session will be recorded and will be available on the CESPN YouTube channel within the next couple of days. At the end of the webinar, a survey will pop up on your screens and a follow-up email will be sent tomorrow. We appreciate your feedback. Please complete this evaluation survey to allow us to issue you certificates of attendance and log RACGP activity. Tonight's event has been RACGP accredited for 1.5 hours of educational activity. We will submit your CPD activity hours for each completed activity with RACGP on your behalf. If you have any questions, please submit these via the Q&A function. We will be able to address these at the end of the presentations. I will now introduce our speakers for this evening. Dr. Jenny Liu is a medical oncology staff specialist and translational lead of the early phase unit at the Kinghorn Cancer Centre, St Vincent's in Sydney. She collaborates with biopharmaceutical sponsors, scientists and clinicians to bring novel first-in-human trials to patients across solid organ malignancies and leads investigator-led trials at the St Vincent's Hospital campus. Jacob Yousif is the team lead for oncology clinical trials within GU, GI, head and neck, and melanoma space at the Kinghorn Cancer Centre, St Vincent's, Sydney. He facilitates the operations of oncology clinical trials at the site and coordinator level to ensure patients have access to a diverse range of clinical trials. I will now hand over to our speakers. Thank you.
Thank you so much, Ruby, and to the team here for the invitation to speak. I'm just going to start by sharing my slide. And just checking, can you see the right presentation view for the slides?
Just need to swap it over.
Is that better?
Perfect.
Okay, great. All righty. So as Ruby mentioned, I'm a medical oncologist at St Vincent's Hospital, and today Jacob and myself will be going through with you covering some overview of the landscape of clinical trials in oncology and really the rapid pace at which new therapies are becoming available for our cancer patients. We'll also be overviewing implications of cancer treatment in terms of managing comorbidities in the primary care setting and help you become a bit familiar in terms of the patient journey when one of your patients is enrolled on a clinical trial and some of the novel patient-centric processes we are trying to roll out to improve patients' quality of life and reduce time and other toxicities on treatment. And I think there'll be plenty of time for questions as well. So I'm sure everyone in the room is familiar in terms of clinical trials are a form of interventional research study and often involves patients accessing novel treatments. It doesn't necessarily have to be drug treatment, can be surgical, radiation, imaging, etc. But these are often done within the context of a study to help us understand toxicity, benefit, and help move the field forward. Certainly, cancer treatment has come a long way over the last few decades and historically involved more disease-specific classifications of cancer based upon the tissue of origin. And we move more to the microscope and understanding histology to guide treatments And this has then led to clinical trials often conducted in discrete phases. However, the process by which novel therapies become approved can take a long time, over 10 years, which really is not quite fast enough for our patients. Often it can be very difficult and expensive conducting these traditional phase 1, 2, then 3 trials. And often the control arm of randomized control trials can be outdated by the time the results are available. Heterogeneity in terms of patients as well as tumors can also affect interpretation of the results. And what we have seen recently is a shift away from organ-specific diagnoses and treatment, such as treatment of breast cancer or breast cancer patients getting the same therapy, to more biomarker stratified treatments, so that patients with hormone receptor positive breast cancer get specific hormone therapy, HER2 positive breast cancers get HER2 targeted therapy, etc. But nowadays, increasingly, our cancer patients are undergoing comprehensive genomics or sequencing of their tumor to understand the mutations that essentially are the Achilles heel in that cancer, and then being able to receive matched therapy based upon those mutations. And examples of this include PIK3CA mutations, commonly found in hormone receptor positive breast cancer. And what we envision, hopefully in the not too distant future, with the use of artificial intelligence, machine learning, and multi-omics, so not just genomics, but incorporating other layers of omics, such as transcriptomics, proteomics, is really tailored treatment N=1 for the individual patient based upon their specific characteristics of their cancer. So today we won't really have time to go over all the different classes of medications available and what's emerging in trials, but and across all the different cancer types, but wanted to broadly go over the common categories. I'm sure many have looked after and are familiar now with the broad range of checkpoint inhibitors or immunotherapy drugs now available and standard of care, and PBS reimbursed for many cancers. Melanoma really has paved the way for this, but other cancers where we use immunotherapy frequently include lung cancer, bladder cancer, renal cell cancer, skin cancer, etc. And these drugs work by awakening patients' immune system, and then these immune T cells are able to then attack the cancer, and some patients can lead to long-standing remission. We are increasingly off the back of COVID, the development of mRNA vaccines, and many of these are in clinical trials still. We don't yet have an mRNA cancer vaccine that is PBS or FDA approved, but some are showing very promising results and often synergistic with checkpoint inhibitors. There are increasingly more and more targeted therapies, and these are often prescribed for patients with oncogene addicted tumors, such as EGFR positive non-small cell lung cancer. Some newer treatments that are coming through trials include radioligands, as well as antibody drug conjugates. And these classes of drugs either conjugate an antibody to a radioisotope or to a chemotherapy payload. So essentially, these are like smart bombs, so trying to target the anti-cancer agent into where the tumor is to reduce off-target side effects and toxicities. And what we're doing in early phase trials now is using precision oncology, so matching the biomarker present in the tumor to targeted therapy, so that we're seeing increasingly higher response rates and patients being referred for clinical trials earlier and earlier in their cancer journey. So back in the day, maybe 10 years ago, when early phase trials first started in Australia, it was often those who were treatment refractory, who had exhausted all standard care options, that were referred to our unit for consideration of trial treatment. But nowadays we have many patients stable on chemotherapy, for example, being referred for a biomarker matched clinical trial, and often sometimes waiting many weeks or months for a slot on one of those trials. One example in lung cancer of how trials have really pushed the field forward in the last 20 years. Life expectancy on average for advanced lung cancer used to be around a year, but with the advent of immunotherapy, it's been around 2 years, and with targeted therapy, 3 years or higher. And you can see really the explosion of multiple different types of approved therapies now available in the lung cancer space. When we look in terms of what types of drugs are coming through clinical trials, you can see, and this is data from the IQVIA Human Data Science Institute, a really high proportion of these, multi-specific antibodies, antibody drug conjugates shown in the yellow, and then cell and gene therapies in the teal that have been increasing in the last couple of years. And you can see really high activity in the solid tumor cancer space compared to, I guess, hematology. And clinical trials can really have very tangible benefits for patients. One example of a patient of ours at the Kinghorn Cancer Centre, Beth, she is actually a lung cancer CNC, and for many decades worked and advocated for cancer patients herself, but was sadly diagnosed with advanced cholangiocarcinoma and has been on a targeted therapy trial for a year targeting a FGFR2 fusion that was found through genomic sequencing in her tumor. And because of the trial, she was able to attend her daughter's wedding, was able to travel overseas, and were able to get a 30% reduction in the size of her tumor on a trial when standard chemoimmunotherapy did not work very well to control the cancer. Another example is in this patient who came to our unit with a very advanced lung cancer, and you can see bilateral lymphangitis. She was nearing oxygen dependence and on a borderline of palliative care referral, but within 6 weeks on a KRAS G12C oral therapy with very little toxicity, you can see complete resolution of the lymphangitis and much significant improvement in her oxygen capacity, and able to subsequently ran after her grandchildren, able to travel to Las Vegas, and enjoyed a year with very good control of her cancer. And a final example is immunotherapy. So certain rare cancers, such as sarcomas, are very sensitive to immunotherapy. And this was a patient who initially came to our unit with intracardiac metastases, causing right heart failure and congestive hepatopathy. It was quite challenging actually getting him enrolled into a clinical trial because of the cardiac consequences of his disease. But fortunately, we were able to get his eligibility over the line on the study, and you can see the significant shrinkage of his cardiac mets and normalization on echocardiogram of his heart function after a year on immunotherapy trial. And he's actually continued, is approaching 2 years, and even though the trial has finished, the company has granted him ongoing compassionate access, which is really great to see. And he's from regional New South Wales near Bathurst, and it's good to be able to help patients regionally, not just those within metropolitan Sydney. And so going back to immunotherapy, certainly this is another example of a head and neck cancer patient of mine who had advanced cancer that spread to lymph nodes and lung despite previous chemoradiotherapy. And after 2 years on an immunotherapy trial, his PET scan showed no residual active disease. So it's not uncommon nowadays for us to be discharging patients we once told you have an incurable cancer and the goal of our treatment is to control it. Sometimes we are pleasantly surprised, and the focus then for these patients often shifts into survivorship care, addressing things such as their cardiovascular, respiratory health and fitness, and then other late side effects that can occur as a consequence of these drugs. So because each hospital has limited capacity and a different portfolio of clinical trials that we run, within New South Wales, we have formed this alliance called NECTAR, the New South Wales Early Phase Trials Network. And NECTAR is designed to assist patients find the most suitable trial across the state based upon their mutation profile, but also based upon what hospitals have vacancies on different trials. So oncologists quite often utilize this as a central 1-800 number and an email that, if you had a patient exploring an early phase clinical trial, you're welcome to send de-identified details through this email, and that will go to the inbox of over 15 early phase trialists around New South Wales, and we can reply with information and details on conducting the referral. And then within our own hospital, so recognizing a lot of these treatments can have very unique and challenging side effects. For example, on that FGFR2 inhibitor trial, nail and skin toxicities were almost universally seen. Within the Kinghorn, we've set up this virtual multidisciplinary team, which we call our toxicity dream team. These are specialists working in all different areas that we are able to refer our patients to in order to access timely toxicity management and supportive care. And some of the advantages for patients include the ability to see these specialists at short notice, and the costs of investigations, consultations, etc., are all covered by the company sponsor that the patient is on that's running the trial. So I might pause there and stop sharing, and Jacob will take over in the second half to run you through some more tips for GPs and the journey for patients enrolled on trials.
Thanks, Jenny, and thanks to the assessment team for the invitation to speak today. I'm just going to quickly share my screen. All right. So I guess, further to the NECTAR program, there is also a clinicaltrials.gov website, which basically details all the trials that are available across Australia and the different sites that run these trials. So it is a very handy tool if you do have any patients that you could potentially refer for a trial. Then that is an option that you could kind of refer to, as well as the NECTAR program. In terms of the Kinghorn Cancer Centre, or TKCC, we offer over 100 trials for a number of different cancer types, 40% of which are early phase. And these early phase trials tend to focus on the safety profile of the treatment. This entails establishing the safest dose level and understanding the toxicity profile of the drug. However, we still see a decent percentage of patients with a positive response, despite these trials mainly being adopted to identify the safety profile. In terms of the Kinghorn Cancer Centre, it consists of 4 teams. So we have team 1 and 4. They are our phase 1 oncology teams, and they focus on the phase 1 oncology trials. Team 2, which is the team that I mainly lead, we look after GU, GI, melanoma, head and neck, and brain cancer trials. And we also have a third team that mainly focus on breast and lung cancer trials. If you do wish to refer a patient to Kinghorn, you can always contact this email address and send across the referral there. It is very handy if you are sending a referral, just include the latest blood results and scan results, as well as any comorbidities or current medications, because it does help us kind of filter which trials might be most suitable for them. In addition to that, we do also run, on top of the phase 1 trials, we do run phase 2 and phase 3 trials. So these trials are heavily focused on establishing response rates and also the quality of life benefits for those treatments. So you can see here about 40% of our trials, our current portfolio. This was late 2024. We've since increased the number of trials that we're running, but around 40% are phase 1. You'll see about 25% are phase 2 and 36% are phase 3. And on the diagram to the right, you'll see that we offer trials for a number of different cancer diseases. So a large number being phase 1 oncology. So with our phase 1 trials, they offer, they could be phased, so they could be disease specific, or they could be bucket trials where they offer treatment to a number of different cancer types. And we also hold a very large prostate setting as well, so as well as melanoma and breast. So we run phase 1, phase 2, and phase 3 trials. We are the largest phase 1 unit within New South Wales, which we can see in the charts. So good option. In terms of the patient journey through trials, so basically, when a patient is suitable for a trial and it's identified, it's mainly dependent on the patient's cancer type, their prior therapies, and if they may have any target mutations or pathways that could potentially be inhibited. Many patients nowadays undergo molecular sequencing to identify their most suitable treatment. And that's, as Jenny was speaking to, we're looking at precision oncology and precision medicine. Once a trial is identified, we'll usually organise a clinic appointment so that they can meet the team here at Kinghorn, and we can provide them with a copy of the consent form, which usually just provides a brief summary of what the trial involves, the therapy that they'll be receiving, the activities involved in terms of frequency of visits, as well as any potential side effects that they may be affected by while on treatment. So at this appointment, we'll discuss the trial in detail, the logistics involved, and obviously we give them the opportunity to review this with any family or friends that they wish to before actually signing consent. Then we'll usually organise for a follow-up appointment where, if the patient does proceed with the trial, they'll consent to the trial, and then we'll begin with our screening procedures. So usually with all the screening procedures, we have about 28 days to complete that. Also, what that encompasses is disease assessments to ensure that they have measurable disease, if it is required by the protocol, looking at their blood parameters to ensure that they're all within range, and nil comorbidities that may impact how their body may cope with the treatment. Once they commence the trial, patients will attend clinic regularly for treatment. Depending on the trial, the frequencies of the visits vary. Some may be weekly, fortnightly, others could be monthly or even bi-monthly. And during these visits, patients undergo numerous assessments, including PK and PD sampling, local blood tests, vital measurements, ECGs, just to ensure that they don't have any side effects. Particularly with a lot of the drugs nowadays, they can cause changes to their cardiac rhythm or hypertension or hypotension. And then we also have a response and toxicity assessment to ensure that the drug is working. So usually patients will have progress scans to determine the effects of the treatment and the response to their cancer. Patients are reviewed regularly by the oncologist and investigators to determine any toxicities, and these are always relayed to the sponsor because they're particularly in the phase 1 setting, they're wanting to know the safety profile of the drug. If a patient on trial does present to you in the clinic with a new problem or side effect, it's really good to let us know if you can. The sooner we know, the better, so that we can inform the sponsor in case it's an unexpected adverse event, which, with these trials, a lot of them tend to be running globally. So anything that we report, they will report that to other sites across the world. And then following that, unfortunately, most patients will progress while they're on trial. So we'll continue to contact them for survival follow-up purposes. However, there are a number of fortunate patients that have complete response and remain in surveillance. So in terms of the patient journey through trials, from my perspective, so clinical trials can support patients in their cancer journey for numerous reasons. So they'll have access to the latest and most advanced treatments. As Jenny mentioned earlier, we have novel agents, immunotherapies, CAR T cell or CAR T cell like therapies. They also receive expert medical care, so they're seen by renowned medical oncologists. They're well versed with the latest treatments available. They also have a clinical trial coordinator to guide them through their cancer journey. So, we'll organize all their appointments, scans, any kind of additional appointments where they might need to see a dietitian or a psychologist. Particularly in the GU team, we have the men's health clinic, which you may have heard of, which we refer a lot of our prostate patients to. It also provides them with a sense of fulfillment by contributing to future cancer treatments as well as future research. So they have a real sense of gratification when participating in cancer trials. They're contributing to medical progress and also gaining a stronger understanding of their disease, providing them with, I'd say, more control of their cancer journey. And I guess that's really helpful to them as it eases their anxiety, particularly being at such a vulnerable stage of their life. So many patients are motivated by the desire to help others and contribute to the advancement of medical knowledge. And it also provides these patients with better outcomes as well as alternative options. So a majority of the trials are focused on precision medicine, which theoretically entails a better response to treatment and reduced side effects. Although clinical trials are viewed as the last result, recently they have become a routine option for cancer patients. And touching on what Jenny mentioned, a lot of patients, they'll have one line of therapy, and then if they have any targeting mutations, they might come through to our units and be on a trial for however months, maybe even years. And then, if unfortunately if it does fail in the future, then they can always return to those standard of care options. So they're an alternative option when standard treatments fail or become too toxic, where patients have minimal quality of life. And it is trying to find that balance where they're responding to their cancer, maybe responding to the treatment, but also providing them with quality of life and being able to spend time with their families and friends, enjoying birthdays, Christmases, that kind of thing. So, of course, there are many challenges and requirements of patients while they're on clinical trials. So clinical trials can be quite intense with the number of site visits and blood tests required. So this can be very challenging for patients, particularly those still working or wanting to travel. In terms of our unit, we obviously do our best to accommodate, as we want our patients to have improved quality of life. There are many protocol restrictions that patients need to be mindful of, particularly with medications, procedures, and vaccines. Hence, patients are always informed by the studies team to contact us if they are to be starting any new medications or potentially undergoing any procedures. There's also major uncertainty amongst patients when starting new therapies. Many weigh up the potential benefits against the potential side effects. Patients can get sick very quickly on new dose levels or combination therapies. So how can GPs support clinical trial staff? So it's crucial that GPs be aware if their patient is on a clinical trial. If patients present with any unusual side effects, please contact us for awareness and management. We'll usually provide all our patients with a contact card at the Kinghorn Cancer Centre, which will have the contact details of their trial coordinator. And if they're on a phase 1 trial, it'll also have the contact details of the phase 1 investigator or medical oncologist. So patients will usually keep this handy in case they need to ever attend to their local clinic or ED. It's important also, when prescribing new medications or vaccines, to contact the trials team or remind the patient to contact us. We can always confirm with our pharmacy department to ensure that there's no drug interactions with the investigational product. And if there are any interactions with selected prescribed medication, we can always look at alternatives. So, we're trying to avoid drug-to-drug interactions. Obviously, sometimes with immunotherapy, we're hoping to heighten the immune response, and prescribing something like steroids would then cause that patient to become compromised, and it would possibly reduce the efficacy of the drug. Vaccines, so particularly live vaccines, these are some things that can kind of affect the eligibility of a patient coming on a trial. So it's really important to kind of note that if they are presenting to the clinic and wanting to get a certain vaccine, that's a live vaccine, and are on a clinical trial or are wanting to go on a clinical trial. Also, with certain procedures and surgery, there's a washout period. So this could be anywhere between 2 to 4 weeks. So, if they have surgery, then they may need to wait at least 2 to 4 weeks before they can start a trial. So if a patient does screen for a trial and then, for whatever reasons requires surgery, it might result in them screen failing, and then we'd have to repeat all the screening procedures. Also, if any patients have any admissions, then this needs to be reported to the sponsor running the trial. So if you do have any patients that are admitted and you could let us know, that would be greatly appreciated. I'll just run through a case study. So this is the TikTok trial, and no, it's not the app. But yeah, so this was a patient on a combination therapy in the ovarian cancer setting, which was a combination of tamoxifen and subutetraconazole. They're obviously well-known drugs with tamoxifen in the breast cancer setting and subutetraconazole as an antifungal therapy. But you're obviously using it in a different setting in the ovarian cancer setting. This patient presented to their GP with upper respiratory tract infection symptoms, and the GP at the time prescribed azithromycin, and the GP as well as the patient forgot to inform us at that time. So the patient started the antibiotics, which was a major drug interaction with tamoxifen, and a couple of days later they presented to our site with QTC prolongation, and then we obviously withheld the IP as well as the azithromycin. So you kind of see an example there. In terms of ECGs, you could see at baseline, her QTC and QT interval is normal. Same with cycle 1, day 8. Come cycle 2, day 1, where she's had the azithromycin a couple of days earlier, you could see that there's the QT prolongation, particularly with the manual QTCF increasing. So what we need, obviously we want to avoid this scenario, is the patient in this case was basically off the trial medication for 4 days. And in other cases, it could be weeks before a patient can resume IP. The main reason that we want to avoid this is, this scenario can create a lot of anxiety within a patient, particularly when they're required to withhold treatment. Because if the treatment's, keeping their cancer stable, or better yet, their cancer is responding to the treatment, then obviously it provides them with increased quality of life. So major drug interactions not only could potentially lead to serious side effects as hypertension or arrhythmias. They can also prevent the drug from being absorbed correctly, essentially negating the effects of the cancer therapy. So it's really crucial, if any patients on a clinical trial do attend to the GP clinic, and you're planning on prescribing some medications, it's always best to check with the trials team. So some trials have released letters to GPs to inform them regarding potential CYP3A4 and QTC drug interactions. This particular example is from our Relay 2608 trial. It's a novel combination targeted therapy trial for breast cancer patients. So you can see, these are the prohibited strong inhibitors and inducers of CYP3A4. And it lists all the medications. So this is a really handy tool that we try to send out to GPs for patients that are on this particular trial. And we're trying to encourage more sponsors to provide us with this information, as it's really helpful, and the initiatives to encourage improved cancer primary care within team and collaborate with our GPs. Another thing that we're kind of looking towards is decentralized trials. So basically what that entails is kind of, rather than all the visits being conducted at the Kinghorn Cancer Centre or at the sites, possibly having some of these trial activities being performed ever at the local clinic or the GP clinic. Some of the benefits include like increasing patient access and participation. So, increases patient access to, particularly for those that live in regional areas, culturally and linguistically diverse groups or CALD groups, people with disabilities, as well as people from Indigenous communities. It also enhances the patient experience, so it reduces the travel burden for some patients, where they may need to fly into the Kinghorn Cancer Centre very regularly. For example, it's quite unfortunate, but there is one trial that I'm currently looking after where a patient is having to travel from Orange on a weekly basis, and having to fly in for assessment, so it can be quite difficult, and obviously quite expensive. A lot of the time, the sponsors are quite accommodating and do provide reimbursements for these patients, but it is quite time consuming for the patient, and it can affect their quality of life as well. So, by allowing decentralized trials or being open to decentralized trials, it would hopefully improve their quality of life outcomes. It also offers improved data quality and real world insight. So, Australia being a multicultural nation, decentralized trials will assist in the science being more applicable to the real world, particularly when diversity of participants is increased. So, including people from regional areas, CALD groups, people from Indigenous communities, as well as people with disabilities, is crucial. It'll allow for the data to be more accurate, and even patients, going to their GP clinics for a local blood test means they'll be well hydrated. Their bloods would most likely be more normal. Whereas if they were traveling 5 to 6 hours to come to our site, and you'll probably see that they're quite dehydrated in the bloods. Their creatinine levels might be increased. So it's just things like that to consider. It's obviously also cost saving as well. So patients aren't required to spend on travel or accommodation, and it's really helpful for them. We have had a number of trials, particularly, or namely the SN38 trial, where we were able to get this up and running. So we had a number of patients residing in rural New South Wales, where we contacted the sponsor to request if safety visits in between treatment days could be conducted locally. So the sponsor approved this approach, which was really good, and our coordinators then contacted the patients, local medical practices and GPs to confirm if they could perform the procedures. So usually these procedures are pretty straightforward. It's mainly just a set of vitals as well as a set of bloods, which we'll usually provide the request form, and also like a urine sample as well, so urine dipstick. So, and the vitals, it's mainly just your BP, heart rate, respiration rate, temp, and oxygen sats. Also, we had this opportunity with when during COVID-19, there were a lot of cancer centers that actually shut down their unit entirely and couldn't really provide treatments for patients. Whereas during that period, we were able to organize for community nurses to administer IP within the home. And during that period, they would be in contact with a doctor at that time via telehealth during the infusion, in case of obviously any infusion-related reactions or other toxicities. We've also managed to treat patients at their local treatment centres. So we had an immunotherapy trial known as AK104, where we were able to treat a patient in their local centre in Canberra for the last 5 cycles of that trial. So I guess the conclusions and takeaways. So clinical trials are a fundamental part of medical oncology treatment and advancing treatment options for patients. For GPs, it's really important for you to be aware of the patients that are on clinical trials and to communicate proactively with the trial team if prescribing any new medications, vaccines, procedures, etc. Just obviously because we want to avoid any drug interactions and want it to increase efficacy. Also, patient enrollment and participation in trials is quite inequitable at the moment. So encouraging patients from regional, CALD, Indigenous communities to participate in trials is important to addressing this gap. That's it. But I think Jenny had one more slide she wanted to share before we move to questions.
Thanks, Jacob. Not
I'll
sure if you
just
can
stop
see.
sharing. Yep.
Yep. Can you see the slide on additional resources? Yep. Yeah. So this
Yep.
is just an outline of a couple of helpful links, including from the Cancer Australia and Cancer Council. If you wanted more information about clinical trials, our hospital website's being revamped at the moment. There's a trial finder tool that is quite helpful, and you can search trials based upon location, the phase, if it's open and enrolling, and specific drug names or targets. And then there is a national program run by Omico at the moment that provides free comprehensive genomic sequencing that a lot of our oncologists tend to refer patients to. So that's got some useful resources for clinicians as well as for patients if anyone's asking you about molecular sequencing. So that's pretty much the presentation side of our session. I can see there's a couple of questions in the chat. Did we want to go to those first or?
Yeah, if you're happy to answer those live, that would be great.
Great, I'll just stop sharing. Oh, good. So there's two from Dr. Zhao Liu. Thanks so much for your very interesting questions. So the first one you've asked is about any factors identified between patients showing, I guess, an incomplete response versus those patients who show a complete response or remission on those drugs. So I suspect you're perhaps referring to immunotherapy drugs, and there are many different reasons why some patients respond better than other patients. So we generally think of those factors to be tumor related and patient related and treatment related. So in terms of tumors, some tumors are just quite hot. So they're very sensitive to immunotherapy drugs. And these are classically cancers like melanoma or skin cancers, because there is a lot of DNA damage, and often, for example, skin cancer due to UV exposure, the DNA damage creates a lot of abnormal proteins or neoantigens, and the immune system has a higher chance of recognizing and attacking those cancers. Then there are, I guess, treatment factors. So one example is how we sequence treatment. So trials that have shown immunotherapy given upfront before surgery, radiation, and lots of other treatment when patients are fitter and more well and robust. And often when there's more cancer around, paradoxically, the immune system has a better chance of recognizing that than if we sequence those treatments and gave immunotherapy after surgery and radiation when most of the cancer has been removed. Some of the patient factors, so people who tend to be more frail or unwell with other problems, if they're on immunosuppression, on antibiotics or steroids, etc., they tend to not respond as well. So in terms of the question about AI, so artificial intelligence, yes, it's really a hot area, and there's actually lots of companies that have been investing in AI treatment and trials. We're using AI now a lot in active research and preclinical research. For example, some technologies allow us to look at thousands of genes and proteins all at once in one tumor, but we need to have systems and machine learning processes to sort of tease the needle from the haystack. I think there's a lot of potential for AI within the clinical space, and I think maybe private clinicians, maybe yourself, are using sort of AI sort of technologies to assist with dictations and notes and things like that. And we would love to be able to use that within clinical trials as well to help us get a lot of information on protocols or get patient files and match them to clinical trials as well. I think some of the bigger cancer centers overseas are starting to do this, but we don't have the capacity yet within Australia to incorporate AI within the clinical trial pipeline at the moment. And then the last question from Cassie. So there seems to be a shift to attempt to shift responsibility in clinical studies to GPs rather than the PI. The trial organization is the one receiving funding, and they should be more responsible to try proactively assist GPs to provide summaries, etc. Yeah, I think that's certainly a really important point, but I think we need to really look at active collaboration. I know that, GPs, you are very, very busy and you're dealing with lots of different issues, not just cancer related and treatment related issues. I think, Jacob, you wanted to speak a bit to this as well?
Yeah, I guess the idea isn't to shift responsibility to GPs. Obviously, we just want to collaborate with GPs and put the patients at the forefront, particularly for those living in rural areas. Just it can be quite a burden on patients traveling back and forth for simple routine visits, like just for OBS or blood tests that they could get done locally. And I mean, obviously, we want to support GPs as much as possible. So if there's any feedback or resources that would be helpful to you, please let us know. We can do our best to develop these worksheets or resources and provide assistance. Obviously, if a patient does attend clinic and you're planning on prescribing a medication, you obviously don't need to contact us immediately, but obviously just reminding the patient, okay, I've prescribed this medication, I've given you this script, just remember to your trials coordinator just to make sure that it's okay. So that's mainly it.
And it can also work the other way as well. Like when patients are on a trial with us, they're very much seeing us sometimes weekly or at least fortnightly, monthly, and we are very happy to renew scripts or, have their other medications that are due or other things tested as well and relay information to you because they're coming to have bloods and seeing us anyway for other things. So certainly a shared care approach moving forward. And then the question below from Dr. Ben Ang about genetic testing for liver cancer. Have to preface by saying I'm not a liver cancer oncologist specifically, but my understanding is that standard treatment in liver cancer involves immunotherapy with bevacizumab, and then in some cases, certain targeted therapies that target sort of VEGF and blood vessel remodeling in those cancers. We have had some trials open targeting a protein, GPC3, in liver tumors. But in terms of mutations present in liver cancer and then matching that to a clinical trial, it's not as a cancer that tends to have driver mutations compared to lung cancer, but still sort of an evolving space at the moment. And then last question about the wait list. So that's a really good question. I think Jacob and I can both speak to this. So a wait list probably refers more to an early phase trial. So in the beginning, when a study is being done to look at what is the right dose and emerging signs of benefit, the company will only allow a small number of patients to enroll and be treated at one time. And that's because we don't want to treat a lot of patients and find there are some serious or even life-threatening side effects. So the first group of patients need to complete at least a month of treatment. We monitor side effects, ensure there's nothing that is life-threatening before the next group of patients can enroll in that trial, and often at a higher dose. So that's the dose escalation process. In that early phase, because the enrollment needs to be staggered, each hospital that's running the trial may have a list of patients potentially suitable that are essentially on this wait list. And spots will come up intermittently depending on how other patients go on treatment. So that's why there can be a queue. Once a study or treatment has moved into a large phase and say this is a phase 3, it's going to roll 1,000 people, half of them will get the new treatment, half get the old treatment. Often there isn't a wait list. So in a hospital that can run and enroll lots of patients, as long as someone's eligible, they'll get referred, and then, yep, Jacob and the team will sort out getting them onto the study. Yeah, Jacob, did you want to add to that?
To be honest, I think you covered all of it. So
Yeah.
Great. So that looks like all our questions for tonight. Thanks so much, Jenny and Jacob, for joining us tonight. And thank you to everyone else who joined tonight's webinar. Again, just a reminder to please complete the evaluation survey that will pop up when the webinar finishes. And we look forward to seeing you all online again soon. Thanks.